Hey, so here we are. After more than 20 years of debate, there's a new psychiatric diagnosis in town, and it's called prolonged grief disorder. Now, from the standpoint of the DSM, the Diagnostic and Statistical Manual of Mental Disorders, there's now normal grief over here and disordered grief over here. And someone suffering from grief-related distress after 1 year could be given this new diagnosis. And as you might imagine, that's what we're here to discuss. And as you might imagine, this has caused a firestorm of conversation and controversy in the mental health field and among those non-professionals who may be grieving. I know many of you are here right now. So are we just further medicalizing and pathologizing human experience? Or does this open the door for more people to get more and better help? Here to discuss. Here we go. This is an extremely complicated story, and we just have an hour. So let me introduce the amazing panel of experts we have. I'm Zach Taylor. I'm not one of the experts. I'm the director of Psychotherapy Networker, which we are sort of the magazine that therapists read around the world for therapists, telling your stories from your consulting rooms. I'm here with Donna Schuurman from the Dougy Center. If you've not heard of the Dougy Center, it's the National Grief Center for Children and Families. Donna is one of the world's experts on grief in children, teens, and families. And Donna, I'd like to invite you, if people want to know more about you and the Dougy Center, where do they go?
Thank you, Zach. Dougy.org, DOUGY.org is our website. And
Sure.
There's a lot of information on there. Thank you.
Sure. Also here is psychiatrist Frank Anderson, internationally recognized trauma expert who just, I wasn't going to say this, but just led an amazing retreat for therapists in Sedona. I've heard nothing but glowing comments. Spent a whole week with him. Frank, where can people go to learn a little bit more about who you are and the work you do?
Yeah, and I just want to thank everybody for having me. I'm honored and humbled to be a part of this panel and to be a part of this really important discussion. So thank you so much for having me. The easiest way to kind of reach me or find me is going to my website, which is frankandersonmd.com.
Yeah, cool. And then we have none other than really the driving force behind putting this together was David Kessler, who is the founder of grief.com, one of the world's leading grief experts, hardly needs any introduction. Also not planning on saying this, but at the height of the pandemic, David wrote an article called, I think it was called "The Discomfort You're Feeling is Grief," when we were all sort of wondering what was going on. This was probably the best thing I read over the entire 2 years of the height of the pandemic. I hope you check that out too. But David, where can people go to learn a little bit more about you and your work?
Grief.com or social media. I am David Kessler.
Great. So a few ground rules, and we're going to jump right in. If you're live, we're going to be taking some questions from those of you who've registered in advance. You can also put your questions and comments if you're watching on social media right now. You'll get the replay if you've signed up. You'll get the replay for the next 30 days if you want to go back and review. Many here are mental health professionals, and this is primarily a clinical conversation. However, I really want to recognize, I have friends on this call who are grieving, and many of you are not professionals. We welcome your voice. We are glad you are part of this conversation because this is not just about professionals telling you how to feel. This is about understanding your experience too. So you are welcomed here. And if you are grieving and you are looking for resources, I highly recommend the Dougy Center for Children and Families primarily, and grief.com has a host of resources and support groups that you can join. And if you're a clinician, last plug, if you're a clinician and you want to go deeper into grief training as a professional, the Grief Summit actually, is happening this week. We actually didn't plan on that, but it's happening this week. At the end of the week, it's 2 days. It is actually free to watch, and the world's biggest grief experts will be there telling you about their latest interventions. So it is free to sign up, Pesty.com/grief22. That's about all we're going to say about it. And then we're going to jump right into our discussion. Okay, let's dive in with David. You have a really unique approach on this and a unique perspective, both as really one of the world's leading grief experts, as well as a bereaved parent, which I don't know if many know. So, David, why is this new diagnosis so controversial and creating such a huge uprising in the field and outside the field?
So first of all, Zach, thank you so much for really helping me put this together. I felt like I needed to address this and I wanted a forum, and thank you for coming on board. And Frank and Donna, I couldn't do it without you. You're both amazing and I appreciate it. So, the first thing I think about is, for me, grief is love. And it is a love letter to those who have died. And it's a love letter that lasts the rest of our life. I have been in this field for decades. And as you mentioned, I've had a loss 5 years ago. My own younger son, David, died. And one of the things after that experience, I said I wanted to write a letter to every person I had counseled, especially parents, saying, I didn't get how bad the pain is, how intense the pain is, how long the pain lasts. And that's why when we were talking about forming this, Zach, I said it's so important we don't do this for grievers, and let's talk about grievers, but not give them a voice. And I'm afraid in this new diagnosis, when I see the language of helping people get over it, I'm like, that isn't the language that grief professionals or people in grief use. We don't get over our loved ones. They weren't colds or flus. Rather, we learn to live with the loss and that love. So I'm so glad that we are talking about this, but it does feel like it pathologizes an experience of love. And my conflict is absolutely, I want people in grief to have resources, to have paid resources, but this feels like it went about it the wrong way by diagnosing something. And I'll have a lot more to say about that, but I wanted to stop there and sort of, that's how I come to this.
Mm-hmm. Donna, let me turn to you if it's okay. What are your thoughts about this? Has been 20 years of debate in the psychiatric community primarily, and you've worked that long or longer with grieving children and families primarily. What's your take? What's your takeaway about this new diagnosis called prolonged grief disorder?
Well, I'll just start out. I'm in alignment with David in the sense that I'm opposed to pathologizing people's responses to the death of someone in their lives. The traumatology field for years has done a great shift in looking at what happened to you versus what's wrong with you. And the title itself of prolonged grief disorder says right there, you're taking too long. And it feeds a misconception that grief should be over at some point in time. And at least with this diagnosis, they're saying if after a year you're experiencing 3 of these 8 symptoms, all of which are normal responses to grief, I think it will perpetuate some negativity. I will say, I also agree that there are people who can benefit and really need some professional support intervention. So it's not binary. It's not either or. I think there are ways to help get people the help and assistance they want without having to pathologize them, because everybody's been doing that up till now before the diagnosis. I'm afraid the diagnosis will be way overused, stigmatize grief, and set us back in terms of our understanding of the lifelong impact of death.
And Frank, particularly coming from a medical background, even though you practice psychotherapy a lot, how might this diagnosis be? How could you see it being misused, both from a medical and a psychiatric perspective, or from a psychotherapeutic perspective? And what are your thoughts about this new diagnosis?
Yeah, thanks, Zach. And I agree with what David and Donna have also said. A couple things that I want to share briefly is that I came to this work of grief a little bit through the back door as a trauma specialist. I'm somebody with a trauma history. I'm somebody who's primarily spent my career working with people who have complex PTSD or relational trauma histories. And what had happened over and over again, when you're repeatedly relationally violated, you experience a lot of loss, accumulative loss. Every time dad got drunk, every time mom yelled and screamed at me, these kids lose their parent, their safe parent. So there's this accumulation of loss that happens with people with complex or relational trauma histories. And then when they experience a loss in life, the death or loss of a loved one, it amplifies the whole past experience. So people have this seemingly exaggerated response from a loss in their life because of this accumulation that has occurred over time with relational trauma. So I became this kind of grief specialist as a result of working with relational trauma. So I just want to name that piece. Mm-hmm. And for me, working with grief is one of the most alive things I've ever done, the most alive work I've ever done, because it's the most real, it's the most authentic. And to rush that process, for me personally, seems ridiculous. So this idea that it's too long or it's a year and therefore doesn't make any sense to me at all. So it's beginning. A year is like, okay, we've just got started, is the way I experience it. So I'm worried about this timeline being, arbitrary in a way that isn't realistic for people. The other thing I do have concerns about is, go to see your psychiatrist, which often is a 15-minute appointment because of insurance companies, and they have to give a diagnosis and a treatment in order to get reimbursement. This is a faulty way our system works. So giving drugs for grief doesn't make any sense to me. There's not a lot of overlap, as we know, between depression and grief, and so to give an antidepressant quickly, or some of the drugs that are being tested, like naltrexone, for example, I get worried about giving a pill for grief. I think there's a lot more to explore than a medication. Now, maybe in some circumstances it can be warranted, but I think the greater risk is to overdo treatment with medications for something that needs to be processed and worked through in connection.
Well, and Franco, can I just add, it was in 2012 when the bereavement exclusion was removed under major depressive disorder from the DSM. Alan Francis, who was the editor of DSM-4, and many others said this opens the door to pharmacological interventions. And we now know from the New York Times article that was published in March that there's already testing for this drug to treat grief as an addiction.
Right.
And the hypothesis, and this is directly from Holly Prigerson and her studies, the hypothesis is that people who have this prolonged grief disorder are yearning and pining and preoccupied with the deceased.
Yeah.
And it says in their article, they're craving their loved ones due to the positive reinforcement provided by the memories of the loved one. So what are we supposed to do? Like create negative memories or?
And I want to add to that, Donna. I publicly discussed this with Dr. Catherine Shearer, and it was talked about as complicated grief then. Now it's becoming prolonged grief. And I literally said to her in one question, I said, are you really telling me, because it was at 6 months and they were worried there'd be backlash of public opinion, so they moved it to a year. I think 6 months or a year are both ridiculous. But I said, are you really telling me at 6 months and 1 day if I'm still missing my son, sad about my son's death, thinking about him a lot, it's complicated grief. And she was like, yep, yes, absolutely.
Mm.
And I thought these time elements are just so arbitrary.
Mhm.
And, it's interesting. I got some pushback to that. Someone said, now that you've had a child die, you're a little biased on this subject. And I went, am I really biased or am I more informed?
Yeah.
I don't think we would say to an oncologist who has breast cancer and survives it that, oh, you're biased now. I think it's understanding it better for me anyway.
When you get to see it from the other side as well.
From the other side, yes, not just professionally, but also personally. And I think so many people, if I had to, think about the most frequent question I get is, am I crazy for still feeling this way, for missing them, for being sad? And of course, I'm saying, no, you're experiencing normal grief. But we live in this get over it productive society that's like, be happy and chipper again and put it behind you. And that's just not real life.
One of the things that I would like to add to that discussion is if we can even tease apart a little bit this addiction element of grief, right? Because there are some people that seem to be stuck on something or that seem to be repetitively holding on to something, right? And so from my perspective, let's get more curious about it. I think adding a drug at that point doesn't make any sense because you block the opioid receptors. With naltrexone, for example, it could thwart or stop a process that's really important to explore. When I'm looking at somebody who might be stuck or repetitively attached to a person in a certain kind of way, we really want to start exploring the underlying reasons for that. That is the way that I look at it. I'm often saying to people when I'm working with them around grief, what is important to hold on to and what is it okay to let go of? Like, we want to look at that a little bit, explore why you're holding on to what you're holding on to, and let's look at that a little bit more. So oftentimes addiction has a positive intention that we need to pay attention to. This is one of the things I do in my work with internal family systems is, what is the positive intention of holding on to something? Let's really explore that. So I think this takes a lot more psychotherapy than medical intervention around getting to the root cause. Oftentimes, I'll say one last thing here, is oftentimes in these prolonged or seemingly complicated grief reactions, there's often an underlying unresolved young attachment trauma that hasn't been addressed. And if we give a med, we're going to miss being able to heal a deeper wound.
Mm-hmm.
And Frank, I just have to jump in there and say, you are a bit of the exception more than the rule. Years ago here in California, physicians were doing end-of-life care so poorly that a law was passed mandating education, continuing education. I was part of that program to teach physicians good end-of-life care and giving them the tools and the resources and understanding how to help in an area they weren't trained to do made such a difference. Yeah. Now, most psychiatrists, most clinicians, psychologists, social workers tell me they got so little or no grief training whatsoever.
Yeah.
So now with this new diagnosis, here's the diagnosis, go treat it. Right. How? Oh, we're not giving you that. That's right. You're just, you got this information. Right, Donna?
Well, there are various proposals for treatment, and one of them is this, a drug for addiction. And Frank, I agree with you that when people, if we could look at people who become addicted to various drugs or alcohol, it's, they're yearning, they're searching for something that isn't happening in their lives typically, right?
Yes.
And so, but the idea here with this drug treatment for grief is that people are addicted to the memory of the lost loved one. Right. And it's based on a study that Mary Frances O'Connor and colleagues did. If people want to find that, it's called Craving Love by Mary Frances O'Connor, multiple studies. But what they did was they showed pictures of their to 21 women, 11 who had been diagnosed with complicated grief and 12 who hadn't, which that whole complicated grief inventory is a mess in and of itself. But they said, and they showed them pictures of their deceased mother, put them in an fMRI, and looked at their, blood and oxygenation levels, and found, and Frank, you'll have to, is it nucleus accumbens or nucleus accumbens in the brain?
Accumbens, yeah.
Okay, accumbens. Well, it lit up and stayed lit up longer in the women who had complicated grief. And their theory and hypothesis was they're addicted to positive memories. So we have to break that addiction.
And Donna, repeat the number of people in that study again.
21. And I love this. The next day or a week later, when the study was done, Jerry Adler, Newsweek magazine, wrote a commentary. He'd had a couple of his own children die. And he said, I've never seen a nucleus accumbens, but I am acquainted with grief. And I can't help but wonder, maybe those women just loved their mothers more. Yeah. So these aren't scientific studies, but they're touted that way. And I think it's really concerning.
Sorry, go ahead, Zach. No, I could just keep going. So continue, Zach.
Let's just catch us up here. A lot's going on in the chat. This is obviously a huge story. You mentioned Dr. Catherine Schuur, who's the developer of a treatment that is for prolonged grief disorder, who was kind of behind this. You mentioned naltrexone, which is a drug that's been used for addictions, now being studied for this. And then Donna brought up an interesting study that seems very small and maybe flawed that has sort of propped up this diagnosis. So what you all are hearing here, just some of the questions that these experts have behind where this even came from. Now, my question is, what else do? We know people come to us as clinicians for grief that feels oppressive, and it's been however many years. I think it's clear to us the length of time doesn't matter, but people come to us feeling, I don't know what to do and I want some help. So David, doesn't this new diagnosis just open the door for more people to get professional help? Now, if they don't meet criteria for depression or post-traumatic stress disorder, they can now get insurance coverage for grief that feels oppressive to them when they show up to their clinician's office. Talk to us about that.
That is such an important door that is open.
Yeah.
Getting more help, an important door. There's a lot of other doors it opened also that may not be good. The idea, you are disordered, you are broken, you need to be fixed, you need to feel better very early on in grief. I believe, and a lot of grief organizations believe, that early grief is the first 2 years. When I tell people that, they go, what? My family, my friends have been telling me I'm in trouble, I'm a mess, I need to get over it. Oh, I thought I was supposed to be done with this.
Right.
And grief doesn't work that way. Donna, what were you going to say there?
I mean, David, you bring up a really important point, which is this whole emphasis on time frame and prolonged. And I don't think any of us are saying, oh, everybody's going to be just fine with time alone. Time doesn't heal, despite the saying, time heals all wounds. No, it doesn't. Not if you don't attend to them.
Right.
The question becomes, how do we attend to them? And one of the things that I think is absent from the DSM as a diagnostic of mental disorders, period, there is kind of lip service given to the social context, but it's not really taking it in. And I do think, I've been in this field 31 years, and I've heard a lot of people talk about this. A lot of the struggles that they're having is because they're no longer being supported by their families, extended communities, their social networks, and their social lives. So yes, they may be avoiding, it may look like they're avoiding reminders of the deceased, but what they're not being invited out anymore as a couple because their child died and people don't want to be around them. So I think we also really need to look at the cultural component,
Right.
And, I will say that a lot of these studies that have been done and the people who are making decisions, many of them in the DSM have ties to the pharmaceutical industry. Their studies are supported by, 69% of people in the committee on major depressive disorder had ties to the pharmaceutical industry. And also, well, no, go ahead.
Yeah, what I would like to jump in, if it's okay, because I wanted to address, Zach, a little bit of what do we do? Like, what do we do with this,
Yeah.
right? And I also want to attach something positive to maybe this will get more people help. It might not be the help that's being suggested right now, personally, exposure therapy or medicine. So I'm not interested in those kinds of help. But if this brings more people into offices to start talking about what's going on, that could be a silver lining in this diagnosis. So I just wanted to put that out there. What to do is do your own work is one thing I would say. Culture, society, and many therapists have a really hard time with pain and loss. I'm going to say this, and I hate to call us all out here, but we go into this field often to help somebody else deal with their problems and their pain because ours is too much to handle. It's easier to be a caregiver and a helper than it is to focus on your own pain. And I will say this personally, doing my own work and dealing with the pain and loss and suffering that I experienced has allowed me to sit with people in their pain. So I do think a lot of us have a hard time being with pain and loss and suffering. It is probably the most difficult feeling we'll all encounter in our lifetime. So can we look inside and deal with the pain that we've experienced? Are we able to sit with somebody and allow them to be in the pain that they're experiencing? And can culture and society, instead of diagnosing it and stopping it, allow people to feel and be with the pain and sorrow that is so rooted in the loss of love and connection, as David had talked about. So,
And I want to mention something along those lines that it happened to me recently. I was speaking at a conference for bereaved parents, compassionate friends, and I was speaking there, and in the lobby of the hotel, there was a young man in his 30s who was just sobbing from his gut.
yeah,
And I immediately thought, well, this is a bereaved father. I know that sound. And every part of me wanted to walk up to him with all my experience. I wanted to walk up and go, how can I help? What do you need?
right.
And I had to force myself
Yes.
to say, may I sit with you or would you like to be alone? And
Beautiful.
he said, you can sit. And I sat for a minute. And then he looked up and said, oh, you're one of the speakers. And I said, yeah. And he goes, all right, let's go in. And we're not trained that there's an intervention called witnessing or sitting or bearing witness to one another and the power of that. So we're all trying to find what to do versus how to be.
Amen.
Exactly.
I had one of the fathers whose child was murdered at Sandy Hook School. Less than a month later, I was doing a group with these parents out in Connecticut, and one of the dads said to his brother-in-law, your relentless need to make me feel better is killing me.
Mm-hmm.
Go home. Like, I need to feel bad. Let me feel bad. And I think, in this quick fix society that we're in, and we want people to move on. And I think a lot of times we want people to move on because just what you said, we don't know how to be present in their grief and their pain and allow them to experience that.
And the sad byproduct of this is so many people have told me recently they've gotten emails. They're in grief. They've gotten emails with the article attached saying from a family member, a friend, see, I knew you were sad too long. You've got to get over it. This article proves it.
Yeah.
Right. Let me also bring up a piece in the neurobiology of encoding traumatic memory here, because there's an important amount of being with it that's helpful.
Right.
Okay. And I think it's important for people to be aware of that. That I did some work in September 11th around critical incident debriefing during the attacks on the World Trade Center. And we know now through trauma processing that there's a repetitive speaking too much about it that encodes traumatic memory in a way that is not helpful. And we also
Like the Mitchell model, right? Is that what you're talking about?
Yeah,
right.
exactly. And then there's also a being in isolation without community and connection that is also not helpful. So being alone in it or repetitively talking about it are both not useful. There is the sweet spot of being with what's difficult and painful that is helpful and therapeutic. So there's a too much and there's a not enough that we want people to be aware of when we're sitting with grief and overwhelming experience. So I just wanted to put that piece out there.
And I think in the middle, for friends and family to understand, grief must be witnessed. We
Yes.
are not meant to be islands of grief.
Yeah, that's right.
I think too, going back to a prior point about training, we have on our website, dougy.org, a grief-informed practices paper. And we came up with 10 tenets of being grief-informed, because trauma-informed has been around a much, much longer time. Yeah. And while there's overlap between trauma and grief, they're not the same thing.
Yeah.
You can be traumatized. Anyway, I won't go too deep into that piece, but so many in doing the research for that, so many professionals, not just psychiatrists and medical doctors, but people who are licensed mental health workers have no training in grief and loss.
Right.
So it's not even, it might be a course in a graduate program in a helping profession. So people, training, it comes back to training and education. And I'd love to see courses in every helping profession in every graduate university in the world. I think that would be helpful.
Mm-hmm. So we're about halfway through our discussion. How we doing out there in TV land? Literally hundreds of comments. If you see me looking off a little bit, it's because I'm trying to keep up with the conversation going on over here. So many people writing in. I just have uncomfortable feelings with this diagnosis. And a few coming in. I'm trying to do my best to tally a little bit. A few coming in saying, a diagnosis is a starting point. It's not meant to label necessarily, but it's how, for whatever reason in our field, people access services. Right. And also that some sort of, I think it was Beth who wrote in that said, when we're meeting with a grieving client and we have to bill insurance, what do? We don't want to label them as having a disorder, but also I don't want to use prolonged grief disorder either. So there's a lot of tension going on just around this that I think we anticipated, that all of us have felt. And I sort of just trying to give voice to the people who are here in the chat, especially non-clinicians in the chat going, I think every bereaved person in the chat, and we see you out there, just so you know, is saying it's been 5 years, 10 years, 20 years, and I continually have reactions, and I have ups, I have downs. To our panelists, I think people are wondering, is this normal? To be 20 years away from the loss of a loved one and still have maybe a sleepless night here and there, memories that you just can't shake. What is normal culturally?
A couple of things I want to say about that, and I'd also love to hear what Frank says about that too. But the reality is, so many people do come forth at 5 years, 10 years, 20 years. And, I always use that proverb, when's the best time to plant a tree? 20 years ago. When's the second best time now? I'm so glad they came forward now. And sometimes, I think to Frank's point, there was unresolved issues in their life before that needed to get worked on then, in addition to the grief. And sometimes the grief did not get the attention it deserved. It got suppressed when the natural time for it to talk about and to be worked through, it got suppressed.
That's right.
And so that's one of the pieces that I think is so important.
Right.
Ideally, and I think this is something people may not understand. We're not deciding and commenting on something the DSM is considering. This is a done deal. But if it ever gets evaluated, which I hope it will, and be looked at even more thoroughly and include people in grief in the conversation somehow, that I do believe there's a way in our world we're so trying to move from dealing with illness and diagnosis to prevention, and not dealing only with mental illness, but dealing with mental health. I would have loved something that talked about grief is a part of being mentally healthy. It is a unique part of the human experience, and you are supposed to grieve this lifetime. Now, in grief, you're going to get mild disruptions. That happens in grief. You're going to get moderate disruptions in your life. That happens in grief. And by the way, maybe we have something, an intervention we can use if the disruptions are really severe. I would have loved, instead of it being a diagnosis, to be around the disruptions and what they do in our life, that's how we intervene, instead of saying, here's what's wrong with you.
Yeah, I totally agree with what you're saying, David. And what keeps popping up into my mind is, I wish this was called complicated instead of prolonged grief disorder, because grief is complicated. It's
Right.
really, really complicated. And maybe the next iteration can include complicated instead of this prolonged disorder. And the complicated, I want to highlight something David said and add the trauma perspective to it. I think about what I call double trauma. There's different types of trauma. Like for me, grief often is included in what I call double trauma if it goes on for a long time in a way that somebody feels like, hey, is something wrong here? Is this the normal process? Or is there something else going on? Because oftentimes grief was never allowed to be fully processed, as David had said, and that ends up being the problem. So 10 years later is because I had a 3-day wake and funeral and I'm back to work and I have to get going so I can be back into life. No time to really process the grief in and of itself. And oftentimes there's an underlying attachment trauma, a younger trauma that, by the way, can be preverbal. Young attachment trauma is often preverbal. People don't have words to it. They're holding it in their bodies, but they can't really articulate it. And so is something else also being activated? Because loss triggers attachment trauma, because attachment trauma is related to connection. So is there also the reason that this is prolonged, if you will, because it triggered and activated something else much younger that has an opportunity finally to be worked through? I often say 3 things when something comes up. Am I going to repress it? Am I going to repeat it? Or am I going to learn from it and work through it? And for me, this is an opportunity with grief to learn through and learn about it and work through it. So I just need to hold that. Yeah.
Back to your initial, where you started, Frank, with complicated and prolonged. I mean, Kathy Shear has been for years wanting it to be called complicated grief. I'm of the belief that grief is inherently complicated because people are complicated and relationships are complex. And I do want to just say something about the label aspect. People say, well, we don't want to label people, but that's what it's doing. We're labeling with a mental disorder. Right. And we say, well, what's normal grief? Well, normal grief is, you go to the funeral 3 days later, everybody goes back to work, you get tuna casseroles, and a year later, everybody thinks you should be okay. So is that what we're, normal is not necessarily something to aspire to. And the one thing I want to add about labels, people say, oh, it's just it's just a label. Those labels are not just have the potential to stigmatize people, but they can interfere in custody battles, in obtaining life insurance, and many other unintended
Even health insurance.
So they're not just meaningless or harmless labels.
Right. And it filters into our society. It becomes, you are taking too long. You are doing it wrong. And one of the things, I have a pretty large online grief group. And the thing that makes it so powerful is that people show up thinking they're doing it and doing it wrong because they're the only one in grief in their world. And then when they get in a world of other people in grief, they go, oh, actually, I am doing this okay. I am doing this right.
And
this is what grief looks like.
That's the essence of a lot of our grief groups with children. We start with 3-year-olds, 3 to 5-year-olds and middle school kids, teens. And when they get in groups together, they can say, well, I'm going crazy, like you use that terminology, but they will frequently because of this, that, or that. And the other kids will go, oh, that happens to me all the time too. And again, not to discount that some people need and will benefit from quality intervention and quality therapy. I'm sometimes accused of being anti-therapy. I mean, I would go once a week if I could afford it. Unless you want to do it free, David, then I'll, but I'm anti-bad
No
therapy.
one's turned away. No one's turned away. And, I want to just mention, I would say probably most people in my grief groups would qualify for this under its criteria. I probably would qualify. And I think it talks about identity and how you're having issues with your identity. How does someone whose spouse dies after 10, 20, 30, 40 years, who every friend they had was another couple, not have identity crisis or issues? Or how does a parent that child dies, how do you just still show up at the PTA with the other parents without a child? Are you still a parent? Are you still a spouse? Are you still married? Grief is about our identity and changing and growing and, accepting these new roles that we didn't choose.
Yeah. And, even words like resolve, we should take away, you don't resolve grief. It's, you address it. And I think a lot of people are suffering because of unaddressed loss. And it may be deaths, it may be relationships, it may be health, jobs, loss of faith, all kinds of things that become unaddressed, and then they become more complicated.
What I'm getting from this,
and then you add COVID to all that. Oh my goodness.
Yeah.
Well,
David,
isolation.
I'll just say there's a thing out there, and I've written a 10-page rebuttal to it, but about dysfunctional pandemic grief, which is really disturbing to me as a concept. I mean, my brother died of COVID. My mother died during the pandemic. So I'm acquainted with all of the hardships that those of us who had deaths during this period of time were not able to have, services, as well as the person who died did not get the memorialization they deserved. So now we're going to make our responses dysfunctional versus the pandemic being dysfunctional.
What I'm getting out of this whole conversation is that, I read that they only think about 4% of the population would qualify for prolonged grief disorder. But from this conversation, I see you shaking your head. I almost feel like every one of us.
A non-person in grief's view of grief.
Yeah.
And Zach,
view.
Holly Priggerson was quoted as saying 4% in the New York Times article. However, if you link to the article of the testing that they're doing with the addiction drug, in there she says 7 to 10. And then you can read it's, the numbers are all over the place. But if you actually look at the symptoms that are in the DSM, they are normal responses to
To
grief.
grief. That's right.
So that, I think,
Can I
is
just
the
read a
most-
couple of them?
Yeah,
Can
go
I just
ahead,
read
David.
A couple of them. I would love for people
Yeah.
just to sort of hear this.
Yeah.
So there's two big ones. Since the death, you're having yearning, longing. In other words, you miss them and you wish they were still alive. Two, you've got a preoccupation with thoughts. You're thinking about them a lot. Those are the two big ones. Then under that, you need three of these. And I can tell you, I'm sure I got three. There's identity disruption, but of course, you have disbelief. Absolutely. Avoidance of reminders. Yep. Emotional pain. I kind of think that's a hallmark of grief. Difficulty with reintegration into life after death. Problems with friends, interests, planning for the future. Well, your friends, you got to look at them on Facebook. They have different lives than you. Emotional numbness, feeling that life may be meaningless, and intense loneliness. Your spouse died? What? You're lonely? Why would that be?
Yeah.
I mean,
Now, what
crazy.
they'll advocate, David, to add to that, though, is that these disturbances cause clinically significant distress or impairment in social, occupational, or other important. But according to who?
According to who?
I
Right.
think anybody, if someone comes into a therapist and says, "I need help,"
Right.
then we're going to believe them.
And that may be 2 months after a death.
Yeah, it
And
may be
sometimes
it
the
may be
person
20
can't
years.
go to work at 2 months, and I want them to help too at 2 months if you can't get to work.
Yeah,
I don't want to say to that person, wait till a year.
right.
So in this, we've just hit on a nerve, it seems, that I think anybody maybe hearing this, anybody in this conversation could say, wow, if a diagnosis can affect 100% of the population, is how clinically meaningful is it? So here it is. We're here. This is a new diagnosis that is right as of now, I think, diagnosable. What do we do when people come in asking about it? Do I qualify for this diagnosis? And how are you all talking to clients and the people you work with about prolonged grief now that this has entered our vernacular?
Zach, can I make an introductory comment? And then I just want to say that I don't know anybody who loves the DSM. Like it has flaws, except maybe the treasurer of the American Psychiatric Association might love it because it's a big income generator. But for ever since it's been around, therapists are utilizing it, sometimes with clients saying, I don't know, which of you has insurance? Here's the least offensive diagnosis I can give you. They're playing with it all the time because no diagnosis fits 100% of the time. So I just want to make that introductory.
And with that, what's going to happen? Like Frank, what's going to happen with the sports medicine doctor who someone comes in for their knee being x-ray and said they've had a loss and they're having a hard time? Oh, there's a new diagnosis, prolonged grief disorder. You got it.
So here's what I would say too, because I'm hearing a lot of what we're talking about here, and it's almost a bit like probably in the group we're preaching to the choir, right? Like a lot of the people that are out there, my sense is, are much more aligned with the way we're feeling about this than maybe the people who created this diagnosis in the first place, right? Well, I have this idea about what if we took advantage of this new diagnosis and used it to our advantage, quite in the way that Donna talks about. Most mental health professionals, most psychiatrists utilize the DSM to their advantage because it's a very flawed system at best. So what if we can know the faulty components of this diagnosis, but utilize it so that more people get treatment, and in fact, they can use their insurance instead of sitting at home and not getting treatment at all. So I wonder about being creative with this new potentially flawed and pathologically oriented diagnosis and take it to our advantage and do something positive with it, because I do believe most therapists out there do exactly that. They'll take these diagnoses and use them in a way that's advantageous to the client. So this is what I'm hoping the message can be, because clearly grief is powerful. It's way beyond what these diagnoses are saying. I think that's pretty clear to all of us. What can we do with that information in a way that can, in fact, help people? It may be a way to get some reimbursement where they previously couldn't, knowing that it's flawed.
And how do we combat people in grief who are in this new unknown terrain,
Right.
now taking on this new burden that there's something wrong with them and they're doing it too long?
That's right.
Or friends and family telling you you're doing it wrong, too long, you're prolonged. The New York Times even says so.
Yeah.
You know, that's part of the challenge too in there, is
That's
to use it and make sure we're working around that and helping people in grief. And family members get educated. Yes, Tom.
One of the arguments that gets thrown out there is some people will be relieved to know that they have a thing that can be diagnosed and treated. But I would reference people that we've spoken several times about the New York Times article. It's by Ellen Barry, and it's called "How Long Should It Take to Grieve? Psychiatry Has Come Up with an Answer."
Yeah.
So that is what started a lot of the firestorm.
Yes.
I'll say that I wrote a rebuttal that was published on the Mad in America site, and it's called "The Grief Pill Is Coming." So, you know, it's kind of a rebuttal to what was brought up in Ellen Barry's New York Times article.
And in all fairness to whoever was involved in that article, most of us here know many times you write an article and the headlines get changed later, and it wouldn't be the headline you might have chose.
Yeah.
So that's another aspect of this too.
Yeah.
Well, I want to switch. I've sort of been working in questions from the audience, but haven't been calling people out by name. I apologize about that. Kind of putting many together. But Frank, I want to shoot you a question here. This is from Kimberly, and she brings up a very interesting aspect of grief we haven't talked about, which is shame.
Yeah.
I don't see that listed in the prolonged grief disorder. Not that that matters so much, but
and does it create shame? By the way, does it create shame?
So does the diagnosis obviously could create shame, but talk about the role of shame in the grieving process and how you see that coming up in clients.
So when I'm sitting with somebody and working with somebody who holds the grief, whether it's current day because of a loss and or rooted in relational trauma, I personally believe that shame is inherent in any grief process. I think it is a natural component because of what culture and society does with grief. It's you get over it, let's move on. There's something wrong with you for feeling this as long as you do. So for me, I don't think I've worked with someone who doesn't hold a level of shame around their grieving process, because culture, society, and now the DSM says there's a certain way to do it and there's a certain time frame within which you are supposed to do it. So I do believe one of probably the main message is, and I say it, I'm playful. Oh, it's only been a year, only a month. Oh my goodness, you're just starting. Like the normalization of the process, which most people are not aware of, does inherently produce shame. I'm wrong, I'm bad, I'm doing it wrong, I'm doing it poorly. So I'm bad because of what I'm feeling, the way I'm feeling, and how long I'm feeling it. So for me, shame is an inherent component of most all grief processes. And I think it's important to acknowledge that. And it's important to name it as such. You'll even see people with the head down looking away. I feel bad for the way I'm feeling for as long as I'm feeling because I'm not supposed to. So yes, I do think it's inherent in all grief responses.
And then
a lot of shoulds. Right? A lot of shoulds.
Yeah,
And
exactly.
I think about our friend and colleague, Brene Brown,
Yeah.
who, of course, makes that clear distinction is about, there's feeling bad about what we did versus who we are.
Yes.
And I think a
That's-
diagnosis can unfortunately make us feel like I'm wrong for
Yeah.
feeling this way.
That's exactly right.
Mhm.
Well,
We're
that
gonna-
goes back to, traumatology saying what happened to you, and thanatology, the study of death, dying, and bereavement, more focusing on, through this diagnosis, what is wrong with you.
One of the things that I teach about when I talk about shame, I have two components of shame. One is, do I know what I feel? And the second is, can I share that with somebody else? Okay. Do I know what I feel? Can I share it with somebody else? The shame reaction comes by the other person's reaction to who I am and what I feel. You shouldn't feel that way. You're wrong. This is taking too long. So it's the reaction of the other that produces the shame within oneself.
Or
And
what about
And
self-imposed shame, Frank? What about self-imposed? Like, I was brought up to think X, Y, or Z, and I don't believe that.
typically that's internalized critical voices that we take in from our parental role. So it doesn't really come from within inherently. It's usually taken in as internalizing the critical voice, because we don't naturally feel that way unless those messages have been internalized.
And shame needs secrecy to survive.
Yes.
When we feel like our grief is wrong and
Yeah.
we are wrong and our friends and family are judging us, we become that island of grief.
That's right. Yeah. Zach, thank you for bringing that up. It's an important component. Of that. So I'm really glad you were able to bring whoever brought that up. Thank you.
There's
Yeah,
also,
give the credit to
guilt,
Kimberly.
guilt, regret. We use the terminology loved one for deceased people, but I've had kids in our groups occasionally say, I know I'm supposed to, but I'm really glad my dad's dead. He was mean. He beat us up. And now all I feel is guilty.
Yeah.
Right.
So it's multidimensional.
We have complicated grief because we have complicated relationships.
Yeah.
Because people are complicated.
People are complicated.
Except us.
No, including us.
Including us. That's exactly right.
We just have a couple minutes left. Thank you all for literally hundreds and hundreds of questions and comments, and sharing your grief experience. I hope you feel seen by those of us in the chat. Barbara Nevins, I'll just read a couple of these. Barbara says, my husband died 2 years ago, and the pain is even worse than it was a year ago. Mm-hmm. How can grief beyond 1 year possibly be considered a mental illness? Mm-hmm. And
sometimes that first year is the numb year, the shock year.
Yeah. David, I heard you in the past, stop me if I'm misquoting you, talk about, are you really grieving? Just because time is passing doesn't necessarily mean you're actually allowing yourself to grieve. And I think that's what Donna and Frank were saying, that time, it's not just time, that we have to enter that process.
It's a strange myth that when our loved one dies, we quit loving them, we quit thinking about them. I think about my son. I actually put on a t-shirt of his yesterday. I hate to think what people would do with that. I send him love every day. He's still part of my life. Yeah. And that's the reality of, I think, what grief looks like. And even the word bereave comes from an old Latin word that means, to be robbed. Mm-hmm. And I think that year anniversary, the Thaniversary as I call it, is a return to the scene of the crime. I think it's an intense period for most people 1 year later. I don't think it's like, oh, I'm done. I'm good now. Thanks, everybody.
Well, this is our moment for some closing comments. So everybody, buckle up. This is your last chance to kind of share how, the clinicians in the audience and those who bereaved, and those may not be separate categories of people here. What would you hope people walk away with from this conversation and from the very positive conversation this new disorders created in our field. Who'd like to start?
I'll start. I would like, especially therapists, and all of us will grieve. It's not distinct. Just because we are professionals doesn't mean we also won't experience our own deaths and losses. I would like people to walk away with wanting to know more, like be discerning, read the literature, look at the Association for Death Education and Counseling offerings, go to David's website, go to Dougy Centers, go to Frank's, and just learn more.
Thanks.
Yeah, and I would add to that I would say each of us here, I have a grief certificate program for professionals. The Dougy Center, Donna does a great educational programs. Frank does wonderful programs. Psychotherapy Networker. I mean, just on the screen, there's more, events and things than anyone could take in. And some are for people in grief, some are for clinicians. So to really utilize them. And the three takeaways I would have is that grief is a natural and normal process. We need to normalize the expression of love. The second thing is for clinicians working with people, it's okay to witness, to not fix. And to three, really intervene only for severe disruptions in our life. And that's what I hope this diagnosis will do, is bring some resources to those severe disruptions without pathologizing the love that is the grief.
Mm-hmm. Thanks, David.
Just for me in closing, I would just like to get across the point that grief takes a lot longer than culture and society and any organization believes it does, and that is a normal process, and to support anyone through their grieving process and allow it to take the time that it naturally needs to take.
Thank
Zach,
you all for
thank
coming.
you. Thank you
Thank
for
you.
doing this. We're a tough bunch.
Oh.
Thank you.
I think we should end where we started, that grief is love.
Yeah.
And so all of you who are grieving, know that this is an expression of your deep love for whatever you've lost. Thank you all for being here. Wonderful panel discussion. And we will hopefully see you all in whatever way you all would like to stay connected to us. Thank you so much for being here. Bye-bye.